Thank you, and welcome everyone to the Ipswich and East Suffolk CCG governing body. And we also have our annual general meeting. When we start, can I ask Joe, have we got apologies for absence? I'm aware of Dr. Holloway being away. Have we got any others?
And Lorna Kerr and Badri from Public Health.
Okay, thank you. So we've got the annual general meeting to start with, and we've got the annual report and accounts and the auditor's annual report to go through. But as usual, prior to Jane and team taking on those items, I'd just like to talk about what's been happening in the CCG over that year, and give a few little updates on developments of the future integrated care system. But really a great opportunity to highlight to you, the public, and our board, more milestones and achievements that have been secured by our practices, and to thank them for all that they're doing that supports the people of Ipswich and East Suffolk that we serve. And just a reminder that a CCG is a membership organisation, and those members are our practices. And this year, the CCG will be coming to a close in March, so next year's AGM will be the CCG's last one. But we will most certainly be bringing a continuity of clinical leadership to the Suffolk and North East Essex ICS. So I'd like to start with some thanks to our CCG GPs who've been supportive of the ongoing transformation work, both the regular work and that required by the pandemic, who've now moved on from the CCG. So I'd like to thank John Oates, who supported the integrated care work, and Imad Khalid, who supported elective care and research, who moved on to pastures new. And John Haig, who many of you will know has been a long time stalwart of general practice at Derby Road in Ipswich, and a creator of mental health developments across our county for many, many years. And he's taken a very well-deserved retirement. I'd also like to make some notable mentions in dispatches for Dean Dorset and Imran, leading a co-production on inequalities with our Black and minority ethnic communities, the hashtag What Are We Missing? And Dean, who is a local, regional and now national guru for social prescribing. I'd like to give a shout out for Aisha, who's a regional deanery role to add to her quite enormous portfolio. Also like to mention Ruth Bushaway as medical director for Suffolk GP Federation. And she's been a fantastic role model of hands-on GP leadership and a great ambassador for general practice medicine for young people. And I'd also like to note our thanks for the PCN clinical directors who have really stepped into the leadership space, particularly through the pandemic, to give fantastic continuity for the future in leadership. And just to say thank you to all of you that have been working so hard in that arena. So 2021 was the year that COVID-19 pandemic really made itself known. Mike Tyson once said, everyone has a plan until they get punched in the mouth. And COVID was that punch. And plans had to be put to one side, and agile planning had to take over. And COVID drove an enormous number of difficult challenges at us. Primary care in Ipswich and East Suffolk rose to those challenges through partnerships, which will create a strong and lasting legacy for the future. Many of the solutions to those challenges were found in the long-term plan for the NHS, and so we accelerated fast into those 10 years, completing many of them in about a couple of months, it felt. And the change to the consultation modes with digital first, balanced by a safe and caring approach to ongoing personal care, the end of life pathways that needed radical change to support patients who needed care, not life-saving interventions. A county-wide visiting service to protect patients and clinicians. Practices working together to manage the hot and cold patients whilst protecting their staff and sites from COVID and the implications associated with site closure and loss of staff to self-isolation. There's no point in being able to support patients if your place was closed and there was nobody there. We really did need to protect those sites and the staff. And there are many other examples, too many to mention them all, and I'm sure as board members you'll no doubt have your favourite. But ultimately, I think we can be safe in saying that practices rose to the challenges. They've been collaborative, they've been fleet of foot, and I think they are stronger for having done so. And we also had the challenge of losing colleagues to the virus, Fayez and Ishwa, and I'd like to thank those of you who've organised suitable memorials to them. So strong relationships were tested and built, trying to mobilise the PPE that was needed, getting the IT infrastructure required, procured, put in the right place and working safely, and the speed of decision making to fund new ways of working and manage unprecedented change in governance nationally in how finances would work and our need to obey central direction in a national emergency. And on their behalf, on our practices' behalf, I'd like to thank the CCG teams, our Suffolk GP Fed and our hospice, the wider voluntary sector, community teams and hospitals for all their support. They helped with providing testing and expert clinical support, doing general practice at scale, providing wellbeing offers. Our Q teams sourced and loaded PPE into the boots of their cars and delivered it to practices and to care homes. The IT and procurement team managed to get the laptops, do the conversion work and got them and the cameras out to where they were needed. And they worked on away from my desk and virtual desktop solutions to allow practitioners to work from home when they needed to work from home. And HR and finance supported staffing solutions, changes to contracts and funding arrangements to support new services, patients and practices. And at the heart of all this, though, was how practices were dealing with every individual needing help, be it those shielding, those needing acute care, those who needed their health monitoring, those in care homes needing safe, expert help with health and care decisions that were in their best interest. Yes, there's always more for us to do and to learn from, but never let it be said that general practice let the system down. It's clear from our national survey that GPs here are still giving great service to patients, no matter what you might hear from papers and news reports, both nationally and locally. Anecdote is not data. Data says that in the eyes of patients, GPs and practices are still a very high-performing system appreciated by patients. Our patients with learning disability have had more and better health checks than at any other time. More people than ever had their flu jab. Our area bounced back in suspected cancer referrals the quickest, and it has supported more quickly online patient consultations than anywhere else nationally. And when it comes to COVID vaccination, local general practice through PCNs and in association with our GP Fed and mass vaccination sites are among the best in the country. The leadership of general practice in this area has been immense, and it has been a humbling privilege to watch how it all works in person and through the various WhatsApp groups. James at Ivry Street and Aisha at Two Rivers leading the way before Christmas, Ruth and David in the Fed with their enormous task of supporting many PCNs at scale and at the same time as managing the day and night job. Our lead GPs in Ipswich, Leiston, Saxmundham, Stowmarket, Felixstowe, Debenham, Hadley, East Burgold, Woodbridge, and all of their staff giving those jabs, they all should be up here taking a bow. The ambition of this team to ensure everyone who needs a jab gets one, creating the vaccination buses to go out and administer to our easy-to-miss populations, working with our amazing volunteers, separate clinics to accommodate those with learning disability or specific ethnic groups, and John Havard at Saxmundham raising money for good causes in support of overseas vaccination as well. But it's been far from plain sailing. Managing the cold chain and other logistical challenges caused enormous trouble at times, especially when combined with snow and ice and in the face of the third wave. And at the start of the vaccination programme, I'm afraid some communities and too many individuals were aggressive, they were rude, they were downright difficult to our staff. It was in their desperation to be protected. But we worked together as a CCG and with our council colleagues and Health Watch alongside us to try and address the concerns in as open a way as possible, and I thank you all for the support you've given. The absolute willingness to provide mutual aid to each other and to ask for help when needed has been a joy to observe. There's a lot of positivity to take from those difficult times. Throughout, we also continue to give attention to our personal and system development through attendance at training and education events. All too easy to just let go of, but no, people wanted to continue their development. The contribution and support to integrated neighbourhood team leadership and active participation in population health management training programme that came through from the national team. So as a membership organisation, we've had 8 full years of accountability, clinically led commissioning, and from April next year, we'll be handing over that accountability to our successors, the Ipswich and East Suffolk Alliance and the Suffolk and North East Essex Integrated Care System. And I think it's important to remember what we wanted to do when we came in at the start of clinical commissioning. And when we did do that in 2013, we wanted to achieve a major shift in thinking about how our system would work. We wanted to remove the perversity of payment by results and instead work towards outcomes that matter to people, not just taking a tick box medicine approach. We were the first CCG in the country to do this. We wanted to develop by building strong relationships and leadership capability, a respectful team of local partners with a common purpose of giving the best quality of healthcare to our population, and that we would do this not through creating a contract, but by actually all personally recognising the interdependency of the relationships we have, and in effect create our own accountable healthcare system. We wanted to create a single clinical community, one clinical community, a cadre of all clinicians from the spectrum that we have across primary and secondary care, community, the biopsychosocial divide. We wanted to strengthen primary care's contribution to the working of our system by developing its ability to work at scale and through effective partnerships in integrated neighbourhood teams, and through the Suffolk GP Fed, of which every practice is an owner. And to do this alongside being the best we can at individual practice level too. We wanted to ensure that general practice had the investment it needed in its contract to work with one clinical system, have modernised estate, regular training and education with protected time to develop and look after itself. And we wanted to remain in financial balance to give us the autonomy of decision making and freedom to make direct investments of our own choosing. And we've done all of these things. In addition, we've created an integrated care academy hosted at the University of Suffolk, a partnership of health and care system, our local council, our voluntary care sector and Health Watch. It's the first in the country. Its aim is to develop and support the integration capability of our workforce and teams, be a source of expertise in how to deploy co-production with our patients and communities so that we tackle head-on the issues of inequality and create an evidence base of intervention, an integrated nature through research based in real work, not just on hobby horses. We want to use data and innovation for the benefit of people in our system and provide a place where the alumni of our leadership courses can continue to network and grow. And I would invite anyone to look at the Integrated Care Academy and think, how might you get involved? So the outcome of all this work over the last 8 years is a local alliance of trustful partners from local government, public health, the voluntary sector, including our hospice, Suffolk Family Carers and Health Watch, as well as the Suffolk GP Fed, our hospital, mental health service, community services. It includes clinicians, medical directors, GPs. It has its strategy aligned to our Suffolk Health and Wellbeing Board and already works operationally whilst developing the capability to work with one budget and really be a partnership of the future worthy of the legacy that our GP membership will leave. The trust equation tells us that trust, the most important factor for success, is the sum of our integrity, our intentions, our capability, and the ability to deliver good results consistently. I hope that you'll agree with me that clinically led commissioning with its membership support in Ipswich and East Suffolk has delivered that in spades. Thank you. So with that, can I hand over to Ed to look at the annual report and accounts, and with Jane too. Thank you.
Thank you, Mark. Thank you for such an excellent introduction. So, Jane, I'm going to hand over to you to talk through the accounts.
Yeah, thank you very much. So included in the papers for the meeting is a short presentation that I'm going to take us through, which covers both the annual report and accounts and the accompanying audit report. So cover items 2 and 3. So and thank you, Mark, for that overall summary. I think we would all agree it's been quite a year that we're reporting on in our AGM, and that has affected our annual report and accounts in a number of ways, and some of that I'll cover in the presentation. But just to say to people who are reading the annual report and accounts and who have been avid followers, as I know some people are, of CCG's progress and the way that we report that through our annual report and accounts, because of the COVID situation for the year that we're reporting on, 2021, and also for last year, the overall requirements for the annual report for the NHS were cut down to allow staff within organisations to focus on the COVID pandemic. So whilst you'll see it's still a very thorough and wide-ranging report, it doesn't necessarily cover the huge scale that you would have seen a couple of years ago. But hopefully, as you'll see from the document, it does pull out a lot of the highlights that Mark has spoken about and gives a good overall summary of the activities of the CCG for the year, albeit in a slightly shortened form. So turning particularly to the financial accounts, the first slide in my deck is around the key messages, and as Mark already highlighted, the good news is that all of our key financial targets as a clinical commissioning group were achieved during the year. We received just shy of £635 million, and that's what we spent. So overall in our accounts, we are reporting a break-even position. In comparison to the previous year, 2019-20, the overall resources received and spent by the CCG were approximately 7% higher. And some of that is obviously inflationary impact, but there's also a significant impact of the COVID pandemic in there. As members will know, the NHS was provided with additional funding during the 2021 financial year to cover the costs of COVID, and some of that came directly through the expenditure that we experienced within the CCGs, and I'll move on to a breakdown of that in the next slide. But just to say, it was a very unusual financial year. Our normal contracting and planning processes were suspended, so that both the CCGs and the organisations that we support, our provider organisations, weren't tied up in contractual discussions and in the processes that surround those. And we moved to a series of block contracts with our main providers for the year, where money flowed through the CCG in a centrally prescribed manner. So what we saw during the year was a very different approach to finances. We also saw different funding streams coming through with the start of the vaccination programme. We saw additional funding coming through to the system to support things like the hospital discharge programme, which enabled us to speed up hospital discharge and also prevent admission. And all of these are part of that additional 7% expenditure. One of the ways that the NHS was asked to help the overall system and was provided with good cash flow to do this was to be a good payer, basically to make sure that we were supporting the overall economy by paying our bills quickly. And I'm pleased to report that in Ipswich and East, we achieved over 97% of our non-NHS invoices were paid within 30 days. And hopefully we played our part there in moving things through quickly and supporting the overall economy in getting the cash out and making sure that we contributed to the overall effort in that way. Just turning quickly to the audit requirements, we've seen quite a significant change in overall auditing this year. That's across the public sector, with a new requirement for auditors to not only comment on the annual accounts, which they do in the report, but also provide a commentary, a narrative commentary on its view on the CCG's use of resources, which sometimes is referred to as value for money. So what you'll see in the audit report is a significantly longer report than we normally have. Normally, we also have our AGM and this report earlier in the year. We would normally have our AGM in July, but those change requirements around the longer report on use of resources has meant that we've been continuing the audit process over the summer, which has resulted in the report that you see today. And I hope you'll agree that that's a useful report, generally very positive on the overall operations and governance that we've got in place within the CCGs. As we move into next year, as Mark said, that will be the final year of the CCG, but with our aspiration with our auditors is that we'll move back to our normal reporting timetable, and that both parts of the audit will be finished in time for the July deadline rather than waiting until September. So moving on to the next slide and diving into the detail of the accounts, there's a pie chart, well, it's a pie ring, maybe it's a pie crust in there, showing an analysis of the expenditure overall and breaking down some of those changes year on year. It'd be unsurprising, I'm sure, to anyone who is familiar with CCG accounts that over 98% of the monies that we spend as a CCG relates to services that we have bought from our NHS trusts and foundation trust, healthcare from non-NHS organisations, primary care and prescribing costs, with that small amount left being around CCG's running costs and other central services. Primary care expenditure on average has increased by 7.4% compared with the previous year, and prescribing expenditure again has increased slightly more than our average of 7.2% compared with the previous year. Now that's not surprising given the COVID-19 impact, and there's been an awful lot of work that's been going on within the CCGs around ensuring appropriate prescribing, but also ensuring that we have the supplies available and the prescribing that's appropriate to deal with the COVID pandemic. So the next slide goes on into, if you're old like me, what you would know as the balance sheet, what's now called the statement of financial position for the CCGs. CCGs are unusual organisations that we don't hold significant amounts of fixed assets. We don't own buildings and things like that. And we also don't hold the majority of our own cash. So CCGs are given a cash limit to draw down on from NHS England, and so we only draw down cash as it's needed, and hence you won't see significant cash balances on our balance sheet. There's some commentary on the side of there around changes in some of the balances we're holding around provisions, and the changes that the financial regime has had on our debtors and creditors, our payables and overall situation for the year. Hopefully, if there is enough detail in there, if anyone's got any questions on those, I'm happy to go into a lot of detail. But overall, no significant changes in terms of our balance sheet, financial position, other than those you'd expect for the changes within the overall financial regime. So my final slide is to talk about 21-22. So we're obviously now almost halfway through that financial year. But it's fair to say that normal financial arrangements have not yet fully come back into place for the NHS. We are gradually moving back, and we are expecting that we will be back to the way that we would normally work. So in receipt of allocations, that we're able to make full decisions across all range of services from the start of next financial year, although details on that have yet to be received. Indeed, whilst we at the moment are in receipt of information on the allocation for the first half of the year, we're waiting with bated breath for information about the second half of the year, which starts on the 1st of October, which is due imminently. We have seen quite a lot of pressures in terms of the uplifts provided to clinical commissioning groups in the first half of the year. So, as I say, we are waiting to hear whether or not there will be any changes around that in the second half of the year. What we do know is that there is an expectation from Treasury and NHS centrally that there will be an increase in the efficiency requirements across the NHS, starting to come in more in the second half of the year, that we affectionately call H2, but particularly as we move into the 2022-23 financial year. As Mark mentioned, we will be closing down the CCGs as entities by the 31st of March, and we will be opening up the new Integrated Care Board, part of the Integrated Care System, and we will be bringing together the 3 CCGs to form that new entity from a financial point of view. But just to give assurance to the board, we are aiming to be able to report at both the ICS, the alliance that's the geography of the former CCGs, as well as at locality level. So we're doing a lot of work within the teams at the moment to make sure that we're set up to do that as we move forward. So Chair, if I may, I'll pause there, and I'm happy to take any questions.
Thank you, Jane. So any queries? Graham, did you want to add anything?
The only thing is, Jane, are you gonna sorry. Are you gonna can you hear me? It seems like I'm getting an echo. Okay. Jane, are you going to say anything about the accounts being qualified and sort of what the value for money use of resources accounts are, or are you going to come on to that, or do you want me to say something about that?
So I'm quite happy to cover that, Graham, if you like. So I've already talked a little bit about the use of resources, the new narrative report, which people can read within there. There's a lot of narrative covering 3 particular areas in the audit report. I think what Graham is talking about when the audit comment on the accounts talks about some misstatements within the CCG's accounts, and this is something that we have spoken at length with the audit committee about. So I just wanted to reassure the committee that this is so how shall I explain this? So CCGs, as you know, we apply for a lot of money during the year, and we sometimes receive that money quite late. That might be money that's for a particular project for the CCG or something that we host on behalf of the system. When they are received late, what we do is we normally account for those as an obligation. So we treat that as expenditure that's happened in the year. And that's been our custom and practice way of doing things. During the audit this year, our auditors felt that this was not an appropriate way of dealing with that, and so picked out some elements as a sort of technical misstatement in the accounts, which they then, through their extrapolation method, they multiplied that up to a figure. As this was below the materiality level for the CCGs, we didn't change the accounts. It's had no impact on the overall just trying to think of the right word there, the overall opinion from the auditors. They've given us an overall clean opinion there. You'll see that there's no issues with the accounts. It's just something that that came up in the audit as a technical issue.
Yeah, so that's what I was saying, Jay. Basically, the accounts are unqualified, and they found no weaknesses in the CCG's arrangements for use of resources. So I mean, it's a complete clean set of accounts that we've had this year, as in the past.
Absolutely.
Thank you. Any questions from the committee? I'm aware of some questions that came in, a couple of which I thought were perhaps more pertinent to the annual general meeting part of our business today. Joe, there are a couple of questions from Mike Hope. Simon, have you got them there?
I do, yes. I've got the questions in front of me here. The questions from Mike Hope are as follows. Nationally, there has been a significant shortage of GPs and a huge decline in GP and GP practice morale due to attacks in the media, mixed messages from NHS England and government, and consequent public hostility. What is the situation in Suffolk and North East Essex with regard to GP numbers and GP morale?
I'm not sure if anyone has any information on GP numbers. Whilst we're waiting for anyone who might, shall we talk about morale? I've got a number of GP colleagues here who may wish to comment, because it has been a major struggle, I would suggest. I think what's been happening and being seen nationally is reflected locally. It isn't universal, but it's certainly out there and making life extremely difficult for staff. Anyone want to say? I've heard of particularly care navigators getting quite a lot of abuse from patients. Care navigators are not receptionists as we would know them. They are there to try and help get people into the right part of the practice or the right part of the system first time. And I'm certainly aware in some practices where they've taken quite a significant amount of abuse of being seen as blockers, and they're not. They're there to help. I know that people have, staff have been challenged within social media personally, and they're anxious about giving their name, and for fear of being hounded. And this is not an acceptable way and worry for people coming to work. People don't go to work to do a bad job. They don't go into the health and care sector to be dragons. They go there to help, and we've seen quite a significant challenge to those on our front lines in practices. Dean.
Yes, just quickly, I think possibly we could flip this on its head and just say thank you. At Burlington, we've had a deluge of thanks and gratitude, recognizing the 5,000 to 7,000 deficit we have in GPs nationally. The vast majority of vaccines that GPs have given us to get us out of this pandemic, hopefully. So I would just say thanks to the care navigators, thanks to the vast majority of patients still being supportive and understanding of the the immense work that every level of our team is doing to catch up on the backlog and to give patients the care that we all signed up to do. I think every GP knew what we were getting to in terms of workload. I think the line possibly has to be drawn at the abuse, that everybody puts their heart, their soul, all of their personal and family time into doing the best for every one of our patients. And it's just a thank you to the care navigators who get the brunt of it. Thank you to our social prescribers, and to those leaders who don't take the easy route of bashing people who are doing their utmost to keep the NHS going.
Thanks, Dean. And yeah, the national shortage in GPs has got bigger every year rather than less, hasn't it? Unfortunately. Any other comments on that particular question? Lolly.
I don't really have that much to add to what Dean said, except to say that I hope that the public can understand that we feel their frustration. We know a lot of it is people's frustration from the year and a half that we've had, the delays in care, and things bottling up that are sort of getting to a head. And we understand that, we feel it, and we feel frustrated in not being able to do more. Where I sit in the practice, I actually sit above our door intercom, and I can hear when patients are coming asking for appointments and can't get one. And you look at our screens, and our screens are rammed, and where our appointments are booked by sort of 11 o'clock, everything's gone, and we're all working flat out. But you feel for the person who's at the door saying, I want an appointment. So we feel it. We feel we're trying, and we're doing our best to give the best that we can within the capacity of the team. So it's not them sort of sitting over there just ignoring all what's going on. We do see it, we do feel it, and every practice is working really hard. But just remember that they're human. They're human beings behind the phones and behind the screens. And who also we also have to access care. If we have children or parents or ourselves who are ill, and we know what the frustrations are, and let's all just stick hanging in there and just try and work through this next. The recovery period is going to be long. We know it will be, but we will get past it if everyone can just to sort of not take it out on each other and just sort of work through it with the best will and the best, giving everyone thinking the best of everyone, that they're doing the best that they can.
Thank you. Aisha.
I think echoing what Lolo has said and adding that it's important to respect, and that's what we do for our patients. We've got full, we really respect what their needs are, and as GPs, as primary care leaders, we are working really hard to provide that. And my biggest fear is if this continues, the pressure on primary care continues, we will not be able to provide safe care, which is very important. And we will drive our younger workforce to other countries like Canada, like Australia, and we don't want to do that. We want to keep them here in this country because we've trained them, and we want the GP numbers to go up. So it's important we just respect everyone when whether it's hospital or whether it's supermarkets or whether it's a primary care navigator. It's important to remember that everyone is human and just carry on doing that. Thank you.
Thank you, Aisha. And there was the second question as well, Simon.
Yes, there was. Yeah, second question. And the second question this is from Mike Hope again. It is reported that the proposed 3% NHS pay uplift should be funded in primary care by GPs themselves with no extra money from the government. Is this the case? And what does it mean for GP services in Suffolk and North East Essex?
Jane, do you want to take that on?
Yes, I can do. So it's important to understand that there's a difference in the way that general practice is funded and transacted by the NHS from other examples such as an acute provider or ourselves as a CCG. So whilst we don't provide direct pay award funding to general practice, the way that this works is that there is an agreed payment per patient through the contracts that we have with general practice, whether they're general medical service or PMS, which is the majority, personal medical services, which is the majority of our contracts. Both of those payments have increased this year. So I wrote down what they were. So the GMS payment has increased by 3.6% and the PMS by 3%, but that is to cover everything, including pay awards, etc. So I won't comment on the adequacy of that, but that is the amount of additional funding that's been passed from the government via the CCGs through to general practice.
Yes, and often there's directions as well with those, such as paying uplifts in wages to staff, which is the right thing to do, but without necessarily funding them. So that has to come out of the one budget that the practice gets, and that's been a common way that the NHS has managed GP payments going back at least more than a decade that I can remember. Any other comments from anyone on that? Okay, thank you. So I'll close the annual general meeting and we'll move into the business of the governing body's September meeting. So apologies for absence we've had. Declarations of interest, any hospitality or gifts. Has anyone got anything to declare over and above that which is already recognised? Don't see any hands, in which case we'll move to the minutes of the previous Ipswich and East Suffolk governing body meeting. Did anyone have any concerns about the accuracy or otherwise of those minutes? I won't go through them by page. Don't see any hands up, in which case we'll go to the review of them matters arising and review the action log. I think most things in there are either on the meeting today or planned for the future or complete. Is everyone happy with that? In which case, over to Ed for a general update.
Thank you, Chair. I just want to start by underscoring the comments made around general practice. We've got outstanding general practice in Suffolk, and they're working incredibly hard. We've got huge demand coming through. Our biggest partnership, Suffolk Primary Care, recorded that they had contact with 23% of their patient list last week, which is a phenomenal amount of work through. So I just wanted to show some solidarity and support to the practices, and the message to the public is to be kind and supportive at this very high pressured time. So the one thing I wanted to add, because we've covered a lot of ground already in the meeting today, was around vaccination as it's moving on to its next phase. So firstly, in terms of our 16 to 17-year-olds, over 70% of them have received their COVID jab, which puts us right at the head of the East of England in terms of progress. And we're working very closely with sixth form colleges and higher education, as well as working with Farnwell and IESCCG and Healthwatch Suffolk around some of our diverse communities. Secondly, NHS England have commissioned a small school age immunisation service to vaccinate 12 to 15-year-olds in our schools, and we're aiming to complete this work by half term. For the 12 to 15-year-olds who are at risk or who are living with people at risk, we're aiming that they'll be vaccinated this week. And then in terms of the booster letters to people in cohorts 1 to 9 will be sent out, are being sent out to, from the national system to invite people for their booster vaccines, and there's a number of pop-up clinics and other routes for people to get their boosters. And so this is for people aged 50 years and over, living in residential care homes for older adults, frontline health and social care workers, people aged 16 to 49 and living with an underlying health condition, and people with an adult household contact of immunosuppressed individuals. So the kind of key message here is that people will be invited from 6 months after they've had their second jabs. In most cases, the vaccine will be Pfizer, and the kind of key message is to wait for your invitation, as everyone will be contacted in those cohorts 1 to 9. It's also possible for you to receive your booster and your flu vaccine at the same clinic. So that was as much as I wanted to cover, Mark, and we'll get into the rest of the detail in the agenda. Thank you.
Thanks, Ed. Just to put in context, the 27% of practice population being in contact with their practice in a single week, that is effectively a doubling of demand on what is usually expected. So we have an average of 5 to 6 patient contacts per annum in a practice. That 27% reflects almost 10 to 12 over an annual basis. So it is an enormous and a sustained rise in demand that we're looking at. And just a reminder to everybody that prevention is always better than cure, that the vaccinations, both flu and COVID, they're for good reason. We thank you for the support to those programs, and wherever possible, when your turn comes, please do come and have your vaccination, but only when your turn comes, please. Thank you. Shall we move on to patient story? Maddie, we were talking about what shall we do about patient stories. It's been an AGM, so is it a time to look back? And I think that's what we've decided to do. Over to you.
Thanks very much. Yes, so within the kind of context of our AGM, what I'd like to do is just to share with you the patient stories that we've received. So 6 of the patient stories that we've received over the last year or so, and just to talk a little bit about what's happened since. But obviously the patient stories have been introduced by many different governing body members, and I'll go through, but I invite everybody to add any particular points that they would like to at the end. So thank you. So in July 2020, Dean, Imran, Fanwell and Louise came to present to us some of the experience and outcomes during the COVID period, but then more widely of our Black, Asian, minority ethnic communities, and discussed with us the urgent need for action to support communities, to protect, for protection. And I don't think at that point, well, we hadn't started the vaccination programme, this was before then, and to support the development of a long-term approach of co-production and working in partnership, working in new ways, in deep and meaningful ways with our communities, and asked us to support the 12 recommendations of the doctors of the world, which we did. And since that time, there have been, and this was begun by the conversation around what are we missing with our communities. And there has been, I think, a positively sustained programme of work led by Fanwell, Imran, Dean, Louise, and our partners with regard to immediate actions, but also just to how we have conversation and how we understand experience, understand how we need to commission differently and how we need to work differently to achieve better equity of outcomes. So I believe we're still fully on, this is a story at the moment without end. It's a long-term commitment that we have made and need to continue to make, both in terms of approach and in terms of action. I'll continue now, but I would hope that Fanwell, Dean and Imran might like to say further. Then the next 2 months, so on the 22nd of September, we welcomed colleagues from the Museum of East Anglian Daily Life, based in Stowmarket, who have been working as part of our wider social prescribing team and adjusted in an incredibly flexible way their programme of work, which is normally based all around the museum, to help people during lockdown. And they described the Skills Kitchen that they had produced, the Book a Garden scheme that enabled people to be outdoors in spaces where they didn't necessarily have their own, and their Search for the Stars volunteering programme, which I was able to see for myself a while ago. So we have made a long-term commitment to social prescribing. We can see the difference that it is making for individuals, and in caring, where it's not medical care that's required, it's social care. It's in its broadest sense. I don't necessarily mean a social care package of care, but it's care within our communities is what people need. And I want to particularly pay tribute to the team and the work stream that's developed that approach, but particularly to our district and borough colleagues and to East Suffolk Council, who has led and held the funds and managed the commissioning process with our voluntary sector. And that's what's been at the very heart of this. And of course, the museum is a crucial part of our voluntary sector infrastructure. And it's our absolute commitment that we will continue. You made a commitment to 4+1 years of social prescribing. We are very keen to continue in this way because it is our voluntary sector that has been so crucial to understanding need and to connecting people with voluntary and community activities that have made that difference to their lives. So again, later on, Dean might want to add on to that. On the 16th of January, we welcomed Mr. Hamill Clark, who talked about his experience of the vaccination programme. And Ed's shared where we have got to with the vaccination programme. And up until recently, until it was announced of the the children's programme and to the boosters, we were seeing some very small daily increases in vaccination. And at one level, that felt like concerning. But on the other hand, it felt very positive for two reasons. The smaller increases was because we had made so much overall progress. And the smaller increases were very important because these were the increases that were in the communities that we knew we still needed to reach out to describe the benefits of vaccination and to give people that opportunity, whether that was closer to their homes than we had originally planned, at their workplace, or in their place of study. And so all of the numbers, every single vaccination, even though the rate of increase might have been smaller over recent months, is so important. Every vaccination really does matter. On the 23rd of March, we welcomed Jane Stevens and James Woolner from Suffolk User Forum, and they shared with us Peter's story, and they described Peter's experience. He had a serious mental health condition, but what he needed most after his annual health check was some listening and some real support with practical matters of finding a dentist, of finding a new GP, with some financial advice. And it was the listening and the time, and it's a little bit like, I think, social prescribing. It wasn't part of the social prescribing programme, but that's what was making a difference to meeting the needs. And I'm really pleased to say that Suffolk User Forum are going to be doing some further work, initially in the Woodbridge area, where I'm a sponsor of the Integrated Neighbourhood team, to see if we can adapt and adopt the same approach there too. And then on the 25th of May, we were joined by Carl and Sasha and Dr. Lulu Preston, who described their incredibly difficult experience of accessing adult and children's mental health services, and the incredibly distressing experiences that they had. I think in 10 years of serving this governing body, I can truly say that it was the most challenging, difficult, but necessary story for us to hear. I think that is my personal reflection, and I know from our conversations afterwards that it was a collective reflection too. And from all of that, Carl and Sasha had worked with Dr. Preston to look at how the services could be improved. And at that meeting, we approved the new personality disorder service and the business case for that. And Richard will give us today an update on how that's progressed. And our last story on the 27th of July was from Richard Passmore, who again shared a very, very difficult experience for his wife and his family in securing joined up dementia care. And Richard spoke to us very powerfully about the need for us to consider how we communicate, the leadership that we give, and our demeanour as we provide service, as we consider how to improve services. And there are a set of immediate actions that we agreed, and we invited Richard to come back to us again in 6 months' time. So, Mark, that was all that I wanted to share. It was certainly for me a really important and valuable experience in just reflecting back, and I hope it was for others. And I would just invite anyone who has been deeply engaged working with the patients on these stories to perhaps add to the conversation. Thank you.
Thank you, Maddie. And I think it's a strong reminder to us that actually quality of clinical care, important as it is, contributes only about 10% to the outcomes we have as from a health perspective, and that health isn't just about physical health, it's about our psychological health and our social well-being as well. It's not just an absence of disease, and so those really important issues are around the wider determinants of health and some of those reflections in something called Maslow's hierarchy of need, which is around what is it that we need if we're going to be individually self-actualized, that we reach the pinnacle of what we're capable of doing is dependent on many, many things, including our health, but not exclusively about that. And we won't get that without consideration of all the factors that we have. And I think the governing body stories hopefully reflect that commitment that we have. Farewell.
Thank you, Chair, and thank you, Maddie, for for that presentation. I think, if anything, what when we went through the process of the patient experience, the purpose was to hear from the people themselves about how our services are working for them or not working for them. And I think it's within that same theme that we set up the What Are We Missing initiative. It was about having the people to lead the process of driving the change that is required. And I think what we have, if there's a takeaway, is that with brave and innovative leadership, we can actually deliver for our patients. The biggest stumbling block has been us saying this is how things are done, and so not wanting to deviate from that, but actually listening to people. They want something different, and we have actually done something different during this process. And then our communities have come back to us. They've thanked us, for some of the things that we've done, outside of the sort of the usual way that we do things. There is a long way to go, and we do not kind of sort of miss that. But I think it's important that what we've started now, we've actually created an expectation, because people have seen that it can be done, that we can do it, that we can step outside of the usual and support and help our patients. And so we need to follow that up by embedding what we've learned into the day-to-day practice. I mean, for example, Matt, you mentioned, when Hamilton Clark came to the governing body, and whilst it's important to hear some of those stories, again, we went further and said, how do we use this to influence other people? And you might have seen on the annual report there, you've got Amil's photograph on the side of the bus. You had people who were hesitant of getting the vaccination, but seeing some of the respected community leaders taking up the vaccination, all this coming from some of the conversations we had as part of the community experience, was very, very helpful in influencing others too. So there is quite a lot of positives, that have come from listening to people coming here, not just informing us, but also helping us to do things different. But I think it's also making sure that we utilize those stories to continue to improve the lives and the experiences of our patients. So yeah, I just wanted to reiterate those points. Thank you.
Thank you, Manuel. And good leadership isn't just about being a leader. It's knowing when to give others the opportunity to lead and work with them to give the best outcome. And I think that's an important factor in a good leadership team.
Yes, just sort of quickly, sort of doubling down on Fanwell's point. I think it's important to listen to the stories. I think it's possibly even more important, and COVID has shown us that were initially sort of made, both at the What Are We Missing, things that came out of the meal experience, every time we engage with the voluntary sector, with the borough councils and those sorts of things. It's particularly important that, as well as the immediate actions of the doctors of the world, that we go into a co-production space where we build the strategy and the solutions together. We need to take the stories that we've heard, the stories that we haven't heard, and take the voluntary sector, the communities and our patients and citizens along with us in forming the solutions.
Thanks, Dean. Ed.
It's just reflecting back on your points about transition, Mark, and how powerful the patient stories have been for this governing body. I think, just a note to the ICS is that I think it's really important we continue to have the tradition of patient stories in the Integrated Care Board as it's established. I think it would be a real backward step if we didn't have that input.
Thanks, Ed. Totally agree. Imran?
Yeah, just reflecting on Dean's points and then thinking about legacy in the future and how important co-production is going to be in the ICS space and ensuring that alliances are picking that up. And also just the worry about austerity and some of the financial challenges we're going to face in the NHS, and just remembering that we've got amazing partners in the voluntary sector who've stepped up this long. And we mustn't lose that funding and that support that we give them, because without them we couldn't do half the job that the NHS does. So it's always a challenge when you've got the system under financial pressure, but that I would say is the big thing we've got to hold on to.
Indeed, thank you. Maddie?
Thank you. I just wanted to end, if I could, I think by formally thanking everybody who has come forward to share their story with us in a public recorded meeting. I've often wondered if I could do something so brave, and I'm not sure I could. So I just would like to thank everyone that has come forward to share their experience, but also to stick with us in helping to develop the solutions and the answers and the way forward, as Fanwell has said, because that must, I think, require immense strength. So if we could formally record our thanks to everyone who's come to this meeting, but more broadly has and is working with us on co-production. Thank you.
Thank you. Thank you, Maddie. And a really nice reflection. Thank you. We have had challenges, and it is about how we step into that space and see some of the leadership that we have and help bring others along with us to, as you say, find those solutions. And I think that would be a good legacy to hand on into the Alliance and ICS space. So thank you. Richard, we're moving on to the update on the personality disorder and complex needs pathway. And over to you. Thank you.
Thank you, Mark, and pleased to be bringing an update on these two important pieces of work. And indeed, both of them link back to the previous item, as Maddie just talked about, in terms of the inspiring item we had in terms of that personal story, and particularly the journey that those two have been on and continue to go on as part of the work to implement, particularly our personality disorder strategy and model. So starting with that one, just by way of background for colleagues, you'll recall that the governing body approved across both this governing body and West Suffolk CCG governing body a £500,000 recurrent investment, importantly into personality disorder services across Suffolk. Has been progress, quite a bit of progress, led by Dr. Preston and our co-production partners. So we've continued with the co-production group to take forward this now into implementation stage. And you'll see at section 1.1 and 1.2 the specific progress that has been made. So just picking out a couple of bits there. There's been 8 needs typing workshops, and there's another 14 being developed and delivered. This was a key part of the personality disorder model, you'll recall. It wasn't about creating an amorphous new service. It was about how do we influence, support the acknowledgement of personality disorder and support personality disorder in all of the different services provided. And you'll see there named some of the particular services themselves that have that needs typing workshop support, and that will continue to be a key part of our strategy as we move forward. There's also been a number of training exercises undertaken, again with different parts of our services, including Suffolk Rough Sleepers, Equity in Mind, and the first response service within NSFT. So again, it's about raising the profile understanding of personality disorder amongst different services and how they can support as part of the offers that they provide. The service is actually ahead of timescale in terms of recruitment, so they have commenced that. You'll recall that the first stage was more about that understanding, building understanding, and the second stage was then getting going with the recruitment to a relatively small team that would provide bespoke support. You'll see that there's further steps building on that through September to November, won't go through them, but effectively it's going on plan and it's tracking well. The only other thing I would add that's not on that page is, again, although Dr. Preston and team acknowledged that this was a great step forward, there is clearly more work to be done within the personality disorder area. So as part of our broader work that we've got underway around developing our mental health co-produced model and implementing it, we've done a degree of demand and capacity modelling across Suffolk supported by Attain, and it is clear that personality disorder is an area that we're going to need in the long run before Jane panics, to put further investment in, we feel, as part of a longer term plan for our community mental health model. So that will be part of the process that Paul and I will be talking around next time in terms of the assurance process related to the mental health model. Turning briefly then to the eating disorders pathway, equally incredibly important area of our work. I'm pleased that both governing bodies, East and West, approved this case earlier this year, and you'll see there's an update in terms of the progress made. So it's fair to say, and Paul and I may cover this later on the integrated performance report, that eating disorders remains one of our most challenged areas. And just to put this in context, the East of England and nationally, we are struggling across the country in terms of the demand for eating disorders specialist service provision. But so particularly with the two KPI key performance indicators, we remain challenged in this area. So having said that, the progress that we're making is good. So you'll see particularly interested in terms of the recruitment. So like personality disorder, with this one, a lot of this was focused around enhancing, bolstering the existing adult and children's eating disorder specialist teams. So when we did the benchmarking work, it did show that we, against the demand that we're experiencing, the current two services didn't have enough capacity to meet demand. So I'm pleased that we approved, and you'll see there's been good progress actually in terms of recruitment. And again, bear in mind that everyone's recruiting as much as they can in this area. So it's great news that we have brought in the extra capacity through NSFT. You'll see there are a few posts that we're still struggling with. You'll see one particularly has been out a couple of times already. So working with NSFT, we'd ask them to think creatively around, is there any additional mechanisms, ways that they can look at this. The clinical lead in this area, and I think he actually came to the governing body, and forgive me, I've forgotten his name immediately. He's a really strong advocate for this, and I think again it's a really good appointment from NSFT to get a new clinical lead into eating disorders, and he's driving the change again in a co-produced way with some of our service users and voluntary care sector groups. And just on that one, you'll recall that a specific part of the solution on eating disorders was a greater degree of involvement directly in terms of provision from the voluntary care and social enterprise sector. And I'm pleased that we are nearly at agreement now with Wednesday's Child and Beat in terms of commencing their enhanced service offering as a partnership with NSFT from the middle of October. And that will support individuals and their families who are either on the waiting list or in receipt of support. So it's similar to the neurodevelopmental model that we brought here and had approved in terms of effectively wrapping around voluntary care and social enterprise support into our core statutory services to enhance support to our local residents. So again, with this one, good progress being made, both though a significant more amount of work to do, and both to be seen within the context of the wider transformation work we've got underway with our mental health and emotional wellbeing services. So leave it there, Mark. Thank you.
Thank you, Richard. Any questions from members of the committee? Ed?
It's just, I mean, you talked about all the strategic ingredients we've put into place, Mark, over a long period of time. I think now we've reached a point where we're embedding the voluntary sector into statutory services in a recurrent way. That's another huge step forward for the future, a great legacy, really, really exciting.
Thank you. Totally agree. Imran?
Yeah, just with Richard's point about the personality disorder service being really only a starter for 10, I think that's a very fair point. And the other real positive that's come out of all this work has been the clinical work group that started meeting on Thursdays to go through the work streams, and that's really developing now. And as a group, we're looking to see how we develop that moving forwards into the alliance space to be a really key deliverable sort of a group that is delivering, and not just from an operational bit, but from a transformational strategic piece as well. So really good engagement from the NSFT consultants and clinical teams. So we're looking to build on that as we've done with our acute sector. So it's a real big step forwards.
Thank you. Very pleasing to hear. Lisa.
I just wanted to mention some of the impacts of personality disorders on the Suffolk population. So I've been working with some of our emergency services on our Section 136 suite capacity. So we know that actually there has been huge pressure on Section 136 ability to support people, and that's had a massive knock-on effect on our police colleagues, our ambulance colleagues, and also the getting the right care at the right time for people in our emergency departments. And we've just done a piece of work looking at the top 10 people who are often brought into our 136 suites, and there's a really high number of those people that have personality disorders, and actually the number of times that they've either attempted suicide or been found on the Orwell Bridge or on railways. And when you look into some of their treatment and past histories, they've had around 300 closed referrals into different services. So actually making sure that these people access the right treatment early in their need for treatment will just make such a massive difference on all our partners. So I'm just so pleased that we're doing this work, and also NSFT have really been supporting the police and are doing a lot of work around education for police on how to support people with personality disorders, which is great as well.
Yeah, thank you, Lisa. And it is about people, isn't it? It's not about what their diagnostic label is. It's about people and their need, and how do we help meet those needs, and reduce the need to the ordinary life. I remember our learning disability team, when they came to us, nobody wants better than a normal life, but a normal life for a lot of people would be really enhancing. Thank you. So I'm pleased to receive and note that update. Thank you, Richard. Given that it's a work in progress, is it something that you want to bring back at another stage, and if so, when?
So I think we'll wrap it into broader update on the mental health work. We tend to do one quarterly. I think this was a bespoke ask at previous meeting. So if it's okay, Mark, I think we'll do this in the context of the wider piece, which we'll bring you back anyway.
Thank you. That's great. So if we can move on, Paul, to procurement update and summary of activity. Thank you.
Thank you, Chair. Paper is to note, and I will take the paper as read, but I'll pick out 2 or 3 things out of the paper if that's okay. Great news around minor surgery in the vasectomy. 10-day standstill has gone uneventfully, and we're now moving into essentially mobilizing of services, and we don't expect to be any particular issues or problems. And we will of course monitor that we would any other contracts. So again, unless there are any issues, we'll just report as and when we move forward. In terms of the last governing body, pathology, service specification have now been agreed. The approach to commissioning process in terms of procurement has been drafted and will now find its way through the various committees for refining and agreeing the final bit of the process, which is really important in terms of commercial procurement. So that is moving at pace now. The last point I would pull out is really around mental health, which we've spent quite a bit of time discussing already. As you know, we've taken a 2-pronged approach to this through the hard work and collaborative work in the Mental Health Board around looking at services that will remain core, i.e. our NSFT providers, and the assurance framework we need to put into place. The workbooks have come in. We've started the process of assuring ourselves the services that meet the needs, that the required needs and the outcomes, and that will continue. And at the same time, we set off our first sort of market test event, I think on the 24th, which was attended by over 100 people, which was really quite phenomenal. And a lot of good work has come out of that, and we are starting to pull together what the framework might look like. So some of the services like crisis, cafe, for example, will be pretty straightforward. We'll start developing service specification and thinking about how we tender those. Some of the other ones like ADHD will require a little bit more work around disaggregating the budget and looking at how we might start look to procure the services and test the market for those. So again, Richard, I'm sure we'll provide some feedback as part of overall sort of mental health feedback, but again, some really good progress on those, and I think some real fruition of some of the hard work and strategic direction we've taken and chosen to take on mental health. And I'll stop there, Mark. I'll be happy to answer any questions.
Thank you. So any questions for Paul? No, in which case, thank you for that. We'll receive and note that update. And on Amanda to Sizewell C development consent order update. Thank you.
Thank you very much, Chair. So this is an update on the Sizewell C developments. Board members will recall that we have received various updates in the past, but I think it's fair to say that we're now reaching conclusion with regards to the initial work that's being undertaken by the team at the moment. But by way of background, we know that Sizewell C is one of 8 sites within our patch that is potentially being identified as suitable for a new nuclear power station before the end of 25. We know that if indeed it's built, it will provide electricity to over 6 million homes within the Sizewell community. We also know that the construction and operational phase is really complex, and in doing so, we have, as a CCG, continued to work collaboratively with our ICS partners across Suffolk and indeed North East Essex. So in terms of the current situation, I think it's fair to say that we have some really good news in that we have put a bid in and received significant financial contribution to enable a health and wellbeing officer to be employed for the duration of the project spanning 10 years. And in effect, this project resource will provide input into a health group which will oversee the development of the Sizewell health building, if you like, that is being set up to support the healthcare for all construction workers over the life cycle of the programme. We have yet to actually see what the design of the Sizewell Health might look like, but we are working with partners and are confident that we will get to see as and when that plan becomes available. But in terms of the contribution, it's in excess of £1.5 million. We've also secured funding to actually buy in GP support, because we believe it's crucial that GP input is provided in terms of the health working group, which is likely to be resurrected around springtime once we have final decision from the Secretary of State. So all in all, I think it's a positive, and a positive for our CCG in terms of ensuring that we provide the appropriate support to the project as we actually move forward. I'm going to pause there and invite Imran, who's been very close to the project, to add anything or anything that I may have indeed missed. Imran?
No, nothing really to add. I think we have a sort of rough understanding of what the on-site facility will look like. It's very much going to mirror the facility down at Hinckley. The only problem we've got is the numbers seem to be slightly different from when we were originally told them. So that's going to be a bit of a work in progress for us. I think originally it was supposed to be between 3 or 4 days of an on-site GP, but the last we heard it was going to be 2. So these are the points that we need to make sure that the health and wellbeing group is staying on top of and managing and helping the system locally to not suffer from the builds. And also, it's probably worth reminding everyone that this is just the first of many in our region. We suspect there's wind farms going up. There was rumours of Bradwell. So as an ICS, we do have to be cognizant of the bigger picture stuff that's happening, and make sure that, you know, for all future builds, we take a lot of the learning from what we've done here and at Hinckley. forwards. So yeah.
Thank you, Imran. Thank you, Chair.
Thanks, Amanda. And Imran, any questions? Don't see any. So in terms of updates, Amanda, how frequently do we need to be having these updates, do you think?
I think the next update would be helpful once we actually hear further information from the Secretary of State. So I think we should bring it forward for early part of 2022 and see where we are at that point. But I'm thinking probably around the springtime.
Thank you. That's very helpful. Thanks. So we're making good progress through the agenda. Can I suggest that we do the next item and then maybe take a 5-minute break and then go into integrated performance report? We'll probably be ahead of time even so with the break included. So Jane, shall we move into the financial planning and extension of temporary financial arrangements, please?
Yes, thank you, Chair. So you'll have seen from the paper that this is effectively a process paper trying to ensure that the governing body is looked at where we are in terms of budgets, allocations and various different committees. You probably sensed a little bit of frustration in my writing of the paper that when I wrote it, we were awaiting our allocations from the 1st of October, and unfortunately that's still the case. The latest date that we've been promised is today, so I'm, as I said in the AGM, waiting with bated breath to see how they are. However, so we haven't. So we do need to do a few technical things as a governing body to make sure that we're secure and safe from a financial point of view, which is what the paper is trying to do. As I say, we are expecting them later today, and we have heard a lot about what is happening. Effectively, they're likely to be a rollover of the allocations we received in the first half of the year. The block contract arrangements with the main providers will continue. We are expecting, as I mentioned earlier, that there will be a bit of a tightening up around efficiencies. So we were expecting enhanced efficiency requirements, which will show themselves as reductions in the overall amount of money received, but not huge ones is what we're expecting. As I say, we'll need to see the detail when it comes through. We are expecting, as I've set out in 2.2, that the block contracts will continue. We'll continue to receive COVID funding and top-up funding that passes through the CCGs straight through to providers. We're expecting that the elective recovery fund, which was put in place earlier in the year to incentivise elective activity, we're expecting that to continue into the second half of the year, and continuation of the hospital discharge programme. In the paper I put partial continuation. We now expect that to continue up until the end of March. So in the light of us not having allocations for the second half of the year, we weren't in a position to be able to bring a budget for that to the governing body to approve. So what I'm asking for permission for is for the Financial Performance Committee to look at the details of the allocation in the budget once they're received. Obviously, that will come back to the governing body so that can be seen in public, but to effectively, if we can delegate responsibility for dealing with the technical issues in the meantime, that would be really helpful. So that's my first area of recommendation. The second one is in line with the fact that we are expecting a rollover of the emergency arrangements that have been put in place, and the fact that we've only now got 6 months for the CCG to continue. I am asking the governing body to extend the arrangements that we've had in place now for the last 18 months around the COVID Resource Approval Committee, the CRAC Committee, which is a committee that works across the 3 CCGs for any decisions that we need to make quickly and to oversee the COVID allocations that we received, and it's been particularly helpful in the vaccination programme. And secondly, we also updated our delegated authority levels in order to deal with any decisions that we needed to make quickly. As it says in the paper, in reality, we've actually made very few decisions in those extended authority levels, but it would just be helpful to leave those in place until the end of the year. Obviously, as we move into the integrated care system, we will be setting up a completely new scheme of delegation across the whole of the ICS. So hopefully, I've run through that fairly quickly, but hopefully it's clear. If we could run through the recommendations, Mark, for the minutes, that would be really helpful.
Thank you, Jane. So in terms of the Financial Performance Committee and the delegated authority there, Steve, you content with that as chair? Yeah. Any areas of uncomfortableness that anyone has on that? I don't see that. So Jane, we're happy with that first recommendation. Going on to the second recommendation, continuing the use of the COVID Resource Allocation Committee and persisting with the delegation levels we've previously approved. Anyone uncomfortable with that? So the way that that's managed is that the CCG governing body chairs act as the chair of those committees, with anyone bringing papers being also supported with senior membership, including Ed or Richard and yourself, Jane, as adding to the governance of that. So are we happy with the continued arrangement through to the end of March? I don't see anyone saying no, Jane. So the second recommendation is also approved. So are we happy with all of that? Yeah. Okay, thank you. So what I would recommend is that we just take 5 minutes or so, maybe come back at 10 to 11, so a little bit more than that. The live stream is going to continue during the break, so if you can switch off cameras and mics, and we'll start again at 10 to 11. Thank you. Welcome back, everyone. So going into the integrated performance report. So directors, over to you.
Do you want me to kick off, Mark? I'm happy to do so, if that's okay with colleagues.
Yeah.
So if I start with the national messaging at the moment, there is an absolute key focus on elective, which I'll talk a bit about. There's an absolute key focus on emergency care and preparedness. There's clearly a focus on cancer care, which is clearly from the concern that we are likely to have a difficult winter. So again, I'll talk a bit about where we've got to as a system. But as part of the report, I'd like to draw your attention to a few things. The first one is some of the work that's going on around community services, and you'll note some of the issues around performance aware on autistic spectrum disorder, or ASD, within the paper, and some of the 18 weeks issues we have in the community. There's been quite a bit of work done with our provider. We now understand that the root cause of some of that underperformance, which is essentially ASD services, and a paper has been drafted, which is, again, will find its way to committees now in terms of addressing some of those issues. There is a combination of things within that. Some historical underperformance, which we know about, so that's picking up some of those issues, and some of the exacerbation that COVID has caused as on the basis of those waiting lists. So again, we will be bringing forward some proposals to try and resolve some of those issues. And I'm afraid Jane isn't on screen, but it may require some additional investment. We will work through those details as we move forward. In terms of elective activity, I'll start off by saying that when you look back, we have consistently achieved above threshold, which is actually the plan. So if you remember, there was an ask that we would need 70 to 85% of threshold, that is financial threshold. We have consistently met that throughout. As part of the accelerated program, we did make a commitment to try and achieve 100% by end of July. Unfortunately, we still don't know because the vagaries of shutting down the financial books nationally, but the figures that I've seen very recently suggest we are 10,000 close to achieving sort of 99 stroke 100%. So again, we won't know for sure for another few weeks. But I think a tremendous achievement, whether it's 99 or 100%, in terms of where we said we would actually be. There is still a commitment to achieving 120%. That is predicated on some of the remedial work happening at West Suffolk and some of the capacity reopening up. That is not likely to happen fully until February now, given some of the delays in the work that is taking place at the moment. But the point I would like to make, that's still a tremendous achievement to have quickly stepped back up the activity that we've done in such a short period of time, and some of the impact that is currently having on the waiting list overall. So when you start looking at the numbers on the doors, what you start to see is we start to see a drop in our over 52-week wait. So from roughly 57 weeks to about 43 weeks. That is 92nd percentile, doesn't take into account long waiters. So roughly a drop from about 7,000 patients waiting to roughly slightly over 4,000 patients over a very short period of time. So again, I think a tremendous achievement, I think, in terms of where we were and the blow that we had around COVID and the stop in elective activity that we saw. But what we are also seeing is a continued rise in our waiting list size, which is a concern. That is in part due to the fact we are also trying to focus on our long waiting patients. And by that, I mean patients waiting in excess of 104 weeks, which is a significant amount to wait for some of our patients, and then moving quickly down to 98 and 78 weeks. Currently in the system, if you look at SNEFT, we have about 21 patients waiting over 104 weeks. 20 of those are all maxillofacial surgery, and we're having regional conversation to try and address that at the regional level. And there are some moves to achieve some of that. So again, from an SNET point of view, done tremendously well to remove a lot of our long waiters, which were actually stacking up at a particular point. Where we start to get some differentials is with West Suffolk. We currently have 89 patients waiting over 104 weeks at the moment, and about 40% or so are dated in terms of the list. So again, a sizable chunk of patients that are waiting inordinate amount of time. You then have to look forward and to say the national ask is that we eradicate 104 weeks by the end of March. And the do nothing scenario points to two specialities, orthopedics and gynecologies, where if we did nothing, we would see in excess of 400 patients waiting for orthopedics. And I'll come on to that in a minute in terms of how we model that through and what we are doing about that, because I think it's an important part of the conversation today. That has led us as a system to work and develop what we've called mutual aid. So in other words, both trusts working in partnership together to try and address some of the inequalities in waiting lists. And we've done a number of things here. We've agreed standard operationalized practice in SOPs, if you want to call them that, in terms of patients being able to be operated by on both sites, irrespective of which hospital trust it is. So we've made some good progress on that. We've targeted a number of specialities for mutual aid, ophthalmology being one of those. And we've seen as a consequence, we've seen a rapidly dropping from 83-week wait to 61-week wait as a consequence of that. So again, really great news stories. Use of private sector, use of mutual aid has been really quite instrumental in achieving some of that. ENT, again, patients have been moved across from West Suffolk to SNEFT, and some patients have been operating. That is supporting some of that reduction. General surgery also. In terms of MSK and orthopedics, we had our second system board meeting where there was a clinical buy-in, clinical leadership to try and address the issue moving forward. And we are just about to set up a workshop to see how we can address the mutual aid and accelerate the mutual aid for orthopedic patients. At the same time, we're having conversation with some of our private sector colleagues. And for example, Nuffield have recently offered another 16 joints a month for orthopedics. So again, some ongoing work to try and address some inequalities and the long wait patients that we have. OMF, in terms of oral maxillofacial, I've already talked about the original conversation, and of course, use of vanguard theatres, etc., are ongoing in terms to try and do some of those issues. So, some really good examples of the system coming together and collaborative working to try and address some of the challenges that we have in our waiting list. The other element that are playing into the factors is clearly nationally they are concerned about the winter we're about to have. There's been a request for short-term capital investment. We've put that into the centre at the moment, and I think submission now is the 7th of October. The 7th of October. We'll wait to hear on whether that will be supported or not. There will then be a conversation about longer term investments, because some of the special required step up in terms of capacity moving forward. But unfortunately, we've not yet seen the planning guidance. We've not yet seen the rules by which we'll need to be playing by. And again, we are ready and having those conversations as a system to see how we can prepare for some of that. So again, Jane has already mentioned, we still don't know what the final settlement is likely to be. So planning guidance is awaited. There will be structural changes to the way funding comes into the system around ERF, and I'm sure the long waiters would be a criteria for achieving further funding and above certain thresholds. So again, that is due at any time now, and we are preparing with that conversation around some of the electives. So in summary, I think we've done really well in the system. There are clearly some huge challenges to be achieved. Mutual and collaborative working is here to stay and needs to carry on, but there is system support to be achieving some of that. But I'm sure you'll appreciate patient choice, cultural issues, hearts and mind of clinicians to make sure we can truly collaborate is something that takes time to build. But actually, we've had some really good starts on some of those areas. Moving on quickly, in terms of the other sort of challenges within the performance, is around emergency care. Now, Mark, we've already heard some of the pressures around primary care colleagues and a doubling, some of the consultations that are taking place. At the same time, our colleagues and other providers reporting that it feels like winter is here. So whilst the activity figures maybe don't demonstrate an increase over 1920 activity, for example, what everybody is reporting is that it is incredibly difficult for a number of reasons. Workforce issues, ICP, sort of managing with COVID restriction are clear challenges around some of that. The ambulance service have been reporting what they call RIP 4, which is the highest level of escalation, for the last several weeks, which has created some delays at the front door. And whilst as a system, we are doing relatively well compared to our other system colleagues, we are still seeing some increasing delays at the front door, and actively having conversation around maybe cohorting patients should things get more difficult as we move forward into the winter. So active planning is ongoing at the moment. We're looking at D2A pathways and capacities. We're looking to see how we can alter some of the pathways that we're currently doing. We're looking to see how we can accentuate some of our admission avoidance schemes, and that will come forward as part of a winter plan in due course through our governing bodies. But a huge amount of challenge at the moment and likely to happen over the forthcoming winter. The last couple of other things just to quickly mention around cancer. The figures still don't show us where we need to be, but there is active conversation with the Cancer Board to try and address some of the issues. And whilst we are seeing a significant increase at 2 weeks referrals, and there is an active conversation about meeting capacity and demand, what we can see through the figures is that we are managed to maintain our 31 days of diagnostic to treatment, which is great news. And when you dig into the figures further, we are also seeing that we're doing reasonably well around our referral to rapid diagnostic 28 days. We're doing reasonably well, which are the other two markers which are really important. Each of the organizations have got active recovery plans in place, which will be monitored and carrying the conversation as we move forward. And finally, I won't touch base too much on mental health because we spent quite a bit of time talking about it, but all the efforts that we've talked about on business cases and procurement are all aimed really to try and improve performance. So I won't say much more about that. So for me, those are the key points within the performance report, and happy to pick up any questions.
Thank you, Paul. And I think it's also important to understand the important role that general practice plays in all of this. The numbers are all in the acute side, but it's not where all of the work is. And there's a couple of areas where general practice plays a really key role. The first is in those first referrals that are made into the hospital and ensuring that we're meeting good standards of information sharing with our consultant colleagues, so that if there's advice and guidance that we can act on in patients' best interest, we can do that and support consultants being able to give advice and guidance rather than add somebody to a long waiting list where the risk for that patient can escalate. The other is in terms of supporting patients to wait well. there is a frustration in practices about the calls that we receive around patients wanting to know where they are in the waiting list, and we don't know that. But in terms of supporting patients to wait well and what that might mean in supporting their long-term condition, for example. And also, it can be very easy for elective care capacity to be overwhelmed by acute patients going into hospital, which we routinely see over winter periods. And, it's not been unheard of to close down some elective care capacity in order to make room for patients who we know will have acute respiratory disease, for example, over the winter months. So ensuring that GPs have teams in the community with whom they can work with to support patients at home rather than going into hospital is again a really important facet of support to this selective care recovery that we're seeing. And finally, in terms of cancer, it is a well-recognised number of, the threshold for cancer referral is around 1%. If we think there's a 1 in 100 chance of a patient having cancer with the symptoms they're presenting to us, we should be referring to hospital for diagnostic opinion, and ensuring that those are done well and the referral is made well is again of importance to consultant colleagues and to patients. So there's a lot going on outside of the acute service in terms of managing that recovery. Lolly.
I didn't know if Paul wanted to come back on something you said first. Should I go?
I'm happy for you to go and I'll come back later.
Okay. All right. Actually, some of the things what I wanted to ask was similar to some of the things Mark has already raised. So, with regards to the waiting list, I just wondered how the acute trusts are doing with, sort of that sort of continuous reassessment of the waiting list to ensure that risk levels haven't changed. So not dissimilar from what the work that has had to be done on the emotional well-being hubs waiting lists over the last few months to make sure that people hadn't moved from sort of green to amber or amber to red. That sort of making sure that, okay, someone's sitting on a waiting list for 50-something weeks. Are they still at a level where they should be? Should they be prioritized, etc., etc.? I think there is something to be said about communication to patients. So I don't know. I'm sure there is some communication happening. It would not seem as much as it could be by the request that we get in primary care for information. I think I know it's resource intensive in some ways, but it would be helpful if secondary care was communicating more with patients who are on waiting lists in a way that gives them reassurance that they haven't been forgotten, but then, also and doesn't, there isn't that sort of, go, because sometimes you get, I guess they ring the hospital, the secretaries then say, well, tell your GP to write a letter to expedite your referral. Well, actually that's not helpful to them or us, because just because we write more letters doesn't mean that they have to move. They have the overall view, don't they, of who needs to be expedited really, and having patients feel like, well, they have to come to us, and that just adds to general practice pressures. So actually being able to have that communicated very clearly to patients, this is what's going on, this is how long it might take, I think is quite useful and would benefit both them and us. And then also thinking about what Mark was saying about waiting well. So we have a lot of patients sitting on some specialties, some more than others, sitting on waiting lists, and we know they're going to be on there for some time. What can we do in the meantime with those patients? Can we think creatively as an alliance and think, okay, what, for maybe patients who are waiting for hip operations, well, is there something that can be done, to manage that, manage that group of patients, whether it's, with doing mind work or diet work, what else can we do to help those patients feel like they're still in control and not at the mercy of the system, that they may not get their operation for months. We struggle with continuous higher and higher prescribing, higher and higher strength prescribing for those patients, and sometimes run out of things to prescribe because they're in so much pain and we don't when the operations will be. What can we do to manage that better for those patients? So just thinking about, okay, what creatively can we do in the interim? And yes, it might involve some resource, but there are lots of patients sitting on waiting list suffering that we can't just leave to, yes, there's lots of stuff going on in the hospital, but we've got to think about how we can support them in the community.
Thanks, Lolly. And just a shout out to our ESNet colleagues for the support they are trying to give patients, particularly around the wider determinants of health, and when they're making contact with them, asking them about their housing, about their social situation, about their finances, and ensuring that if there's more that we can do to support them outside of just their clinical need, that we look to do that. And I'm very grateful for medical directors and divisional leads who are supporting that work. Paul, did you want to come back?
Yeah, just try and pick up some of those key points, if I may. Mark, I think you're absolutely right. The outpatient transformation is absolutely key to that. So the advice and guidance is very much part of the gateways in which we measure against, and then the constant improvement in that is what is expected, and we are monitoring that and developing that service. At the same time, the patient-activated follow-up is clearly a strong feature of that. So again, but we have to accept, don't we, that even if you got patient, then there is some burden that ends up on practices. So again, that collaborative working is really, really important in terms of agreeing those processes and moving forward. Just to give some assurance, the feedback I'm getting from providers, they are actively reviewing all of their waiting lists all of the time. And part of the reason for that is because the focus is on what it's called P1 and P2 patients. So the most urgent patient are the patients we've been asked to focus on. The slight fly in the ointment, if you want to call it that, is you then on the other spectrum a number of patients waiting an excessive amount of time, i.e. 104 weeks, and they may not necessarily be the most urgent patients, which is why it's sort of leading to a bit of a forced curve distribution of what our waiting list is starting to look like. So again, just to give some assurances, the trusts are actively reviewing their waiting list on a constant basis to prioritize the patient they need to bring in. The other point, just quickly to bring on cancer, is of course you can't segregate a capacity cancer from overall capacity. So again, as capacity increases for general conditions or specialities, then by default your cancer capacity increases. So there is a direct link within some of that, and people are really aware of that and working towards that. Then I think it takes us on to the conversation around patient communications. Both trusts will point to all the effort that they make into communicating with the patient on an ongoing basis. But I think you're absolutely right. There is more work that can be done in a collaborative way. And in terms of resources, this is quite an active conversation with the Elective Recovery Board. Part of the Accelerate programme, I put aside some funding which hasn't yet been touched to support alliance working and exactly that reason in that space. So there are some active conversations taking place at the moment, namely the one I've just been involved around the orthopedic board, where we've agreed we needed to look at that in particularly for patients waiting for joints and hip and knee replacements that have been waiting a very, very, very long time. So I think that's a wide challenge. I think it's a wide approach, and there are some opportunities to try and improve some of that approach. So I think those are absolutely the wide challenges.
Thank you, Maddie.
Just to agree with Paul, and thank you, Lolu. I think that is absolutely the right question. How can we? It really is a system response that's needed for individual patients. The whole answer does not sit in ESNet's PALS team, and it doesn't sit in general practice either. So the conversations that I think we're starting to have and need to have, and well, Lolu, you could have got yourself a job if you'd like one in the in the very heart of that conversation and work stream, is about how we can offer a holistic response in a really streamlined way to patients over this period. So as Paul has mentioned, there is some resource to do that, and we need to use it really wisely. So can I count you in? Thank you.
That sounded like a yes. And there's also this emerging challenge around our waiting lists based on the time that you've been on a waiting list or the need that you have, and how is that need actually understood. There's need from a clinical perspective, but there's also need from an inequalities perspective, and the emerging evidence is that need from an inequalities perspective has to be tackled, and just because you might have sat on a waiting list for a period of time, or you might have a clinical rationale for being in a certain place, there could well be and should be a rationale from an inequalities perspective, if we're going to be true to the the words that we say around tackling inequalities. If there's going to be action around to follow those words, then I think we do have to consider that. Thank you. Any other questions for Paul? In which case I'm going to move us on. Is it Lisa, Richard, Maddie?
Thank you. So I'm just going to update on 3 risks that are being escalated to me and some programme information before I come to providers. So the 3 biggest risks at the moment from a quality perspective that's being escalated to me is firstly around access into dentistry. That's being escalated from a number of areas through Healthwatch, through our safeguarding teams, through primary care, and through patients into it's one of our top PALS concerns around access to dentistry, primarily for specialist dentistry, children in care access and emergency access. So I will be recommending to Dr. Qureshi that we have a bit of a deep dive at clinical scrutiny on dentistry. I know we've been meeting with our colleagues in NHSEI with Healthwatch, but it feels like we need to really get a good handle on the access into dentistry for patients in Ipswich and East Suffolk. The second key quality concern as a system is around some of the placement breakdowns we're seeing for people with learning disabilities, particularly living in supported housing, which is having a significant risk and issue not only to the people themselves but to colleagues in other parts of our partnership organisations, and can result in people being placed out of county. So we are really keen to work with our county council colleagues to look at a more integrated way of delivering LD support to ensure that the right people, the right professionals are in the right place at the right time to prevent placement breakdowns for people with learning disabilities. And the third risk that is escalated, which will not be a surprise, is around access to Tier 4 CYP mental health services for children and young people. So just on a programme update, I just wanted to update on our Transforming Care programme in Suffolk. Just to update the board, we currently have 3 CCG inpatients who all have treatment plans and all have discharge dates. Our trajectory is 6, so we're well below trajectory, and we're one of the top performing CCGs in the nationally. So we have a number of requirements that we're required to ensure in place around the CETR process and host commissioner arrangements, visiting schedule, and all are in place. The other programme I just wanted to update on was around maternity programme, reflecting back on how we work with the voluntary sector. I just wanted to update the board on the work that UK Babies has been doing during COVID. So when antenatal face-to-face classes were paused, UK Babies stepped in and developed antenatal online classes, which have really had a phenomenal response, particularly in Ipswich and East Suffolk. They've had hundreds of partnerships attending. People can watch it whenever they want to watch it. They can access it live or they can download it afterwards, which really fits in with accessibility and really supports the woman's partner being part of that, which we know sometimes with face-to-face antenatal classes can be difficult if there are other young children, etc. So their satisfaction rate is something like 98%. It's been phenomenal. It's a pilot at the moment funded through the maternity programme monies until December. So we're about to look at that. One of the key things that women have said and their partners is they would like it to not stop when the baby's delivered. They would like it to go on postnatally. And I think our real utopia would be for it to continue on past the postnatal period as well, because such an area and feeling of support is generated within the class, the virtual classes, that it would seem great that it's kind of carried on and either self-facilitated or facilitated by some of our early years colleagues. So we're just looking at that with our health visiting teams. We've also recruited the Roma community worker in Ipswich and East Suffolk. That person is working specifically with the Roma community, increasing their access into antenatal care and making sure that everything is in place to ensure equality of access and to ensure that everything is understood by the community around the pregnancy, antenatal and postnatal offer. So they are going to be coming to the next maternity board to update on their work, but that's a real positive piece of work. Continuing on the maternity thing, so ESNEFT, they have their Every Birth Every Day programme, which oversees both workforce, safety culture, governance and OD in maternity. In ESNEFT, they have their Director of Midwifery who started, which is fabulous. We're so pleased. And Ros, her name is, she seems to be really getting to grips with everything in maternity. So we're really pleased about that. And SNE was actually commended in the regional team's maternity board for its vaccination programme in antenatal clinics. Both our providers have done really well to take the vaccine into antenatal clinics rather than expecting women to visit vaccination centres. So that's great. ESNEFT have just published their infection control annual report. It's been a bit of a strange year for infection control, as you will imagine, but it's really important that we don't forget everything else in infection control. We've had such a COVID facing 18 months, but we must remember the E. coli bacteremia, the MRSA, C. difficile, etc. So we are relaunching as a system really our strategy in the coming months around how we're going to manage some of the issues that we face in infection control and re-establish our priorities across the ICS. ESNEFT have also reported on their annual safeguarding reports. In their priorities for the next year is to increase their compliance with level 3 training across both adult and children services, to increase their safeguarding supervision in maternity and CYP services, and also a great piece of work to focus on the safeguarding of 16 and 17-year-olds on adult wards, which is really well received by the system. For ESNEFT, you may remember in the action log we had an action to update on SHIMI and HSMR. The SHIMI data is in the IPR, and the SHIMI for ESNEFT to February 2021 was as expected. The HSMR, which is a 12-month rolling figure, was reported as 108.1, and ESNEFT are one of the 6 trusts in East of England with higher than expected HSMR. There was a deep dive at clinical scrutiny last clinical scrutiny around the mortality rates. Other areas, IESCC hosted a multi-agency stakeholder workshop at Worsted Park. We were all socially distanced and precautions were in place, but it was a really good event. It was a very much a listening event from IESCC. Health Watch were there and really had a lot of time to discuss some of their concerns from stakeholders and from care homes and from people that contact them. And we're just working with IESCC to pull together some of the recommendations from that stakeholder workshop. But it was a good event to jointly plan the way forward. Paul's mentioned East. We have seen an increase in incidents relating to delays from response times, and we're giving a very strong steer that any delays that have been a delay because of the ambulance being delayed to respond must be looked at as a system. So we have the regional quality meeting this afternoon for East, which I jointly chair with Juliet, the Don, and we'll be talking to all our commissioner colleagues about making sure that there's a system approach to any incidents reported. NSFT, I think it's reported emotional wellbeing hub is improving, which is great and amazing, and is really pleasing to see. But I think there's still significant demand on all pathways, which are resulting in quality concerns. Thank you. I'll leave it there.
Thank you, Lisa. As you say, infection prevention and control is more than alcohol gel. Alcohol gel won't protect you against the others. Hand washing is still really vitally important. Just a clear message to us all and our public. And antibiotic stewardship is and remains really vital. Got a positive report within the primary care element around antibiotic prescribing, but stewardship of our antibiotics is truly important. So they're not just for just in case scenarios. And just a reminder to our public that antibiotics are an important part of infection control, but have to be managed very carefully. And the responsibility for that does lie with prescribers, not with the public. Thank you. Any other questions for Lisa on those areas of quality? In which case, is it Richard's turn?
It is indeed. Thank you, Mark. Thank you, Lisa. So just three things strategically that aren't in the IPR that's important to update on. So the first, I think Jay may have alluded to, is planning guidance. So I'm the boy that cries wolf with this, but we are expecting planning guidance to be issued today from the National NHS England team, which will then start a process over the next month of effectively developing our second half of the financial year activity finance and narrative plans, which I'll be working with Paul and Jane to coordinate across the three CCGs. So we'll update through the clinical executive in terms of how we're going to be taking that forward. Second is in terms of the direct commissioning responsibilities that currently sits with NHS England. So we received a letter from the new Chief Exec of the NHS, Amanda Pritchard, in late July, which clarified the position insofar as the basket of services that are currently still held within NHS England in terms of commissioning responsibility are over time due to be transferred to the new integrated care system, subject to the Health and Care Bill working its way and being approved through the Houses of Parliament. In effect, that means that from April 2022, that the current services, and Maddie will update probably a little bit more on this if I get this wrong, particularly Maddie, but the current direct primary care services that we co-commission will be coming back completely into the new ICS from April 22. The other services that are held by NHS England, namely optometry, pharmacy and dental, will be shadow form until April 23. And then the view is that ICSs take on responsibility for those areas from April 23. There are a couple of other services that kind of under the banner of specialist commissioning. That will be through effectively a joint committee between the 6 ICSs that make up the region and the regional team, and that is expected to commence from April 22. So there's quite a bit of work happening within that field, and there's a programme board in place which we're represented on through myself and other colleagues within the ICS to take that work forward. So that's the other big strategic piece. And then the final one is there is another guidance document that came out about a month ago, which relates to collaboratives. So effectively from the end of March of next year, the expectation is with each physical acute trust, so ESNEFT and West Suffolk for us, are part of a more formal acute collaborative. So we're in early conversations across the ICS around what the opportunities that would bring about. So effectively more of a partnership between our physical acutes in terms of working at scale across our integrated care system geography where it makes sense. So it very much links back to Paul's update earlier, particularly in relation to elective recovery, where we've got a significant amount of joint work happening now across the ICS through mutual aid and through some of the strategic work we're doing in eye care and musculoskeletal and other areas. That seems the obvious one to start if we did any work. So there 3, Mark, just kind of hot off the press, particular strategic updates. Turning to the programmes, Paul's already covered, I think, some of the headlines related to elective. There are a whole ream of different projects you'll see in the pack, predominantly rated green, most of them led as part of the joint team by ESNEFT that we've got in place. Advice and guidance has slipped slightly, so we are below the 25% national standard. Interestingly, though, our patient-initiated follow-up is up. So actually there is a correspondence between the two because PIFI doesn't count in the advice and guidance piece, which is slightly bizarre because actually through that patient-initiated follow-up work, you're avoiding the admission, the attendant in the first place. So there's some more work to do on influencing through that route. Eye care, we've met twice now as a board. I'm chairing that while Paul chairs the musculoskeletal board. And we're making some really good progress through the clinical interface now, primary and secondary care, and our optometrists through the local optometry committee. So some really good work starting through that. Again, won't repeat some of the same messages Paul gave around our integrated care programme. The majority of the focus is, if I'm honest now, on the operational pressures that we're currently experiencing and how the transformation team can actually focus on supporting the system in terms of our winter planning. So admission avoidance, discharge to assess, and other elements are the major focus of that at the moment. Turning to mental health, we talked a little bit earlier, and again, Paul stealing my thunder gave an update through the procurement update. It just shows we're all joined up. Effectively, we're in the process now of commencing the assurance process with our alliance partners. So there's a whole ream of material that's now coming to be started to be pulled over by the panels that are being put together internally within our CCGs, including our clinical leads. And we will then be going through a panel process with our providers in October and hoping to bring a report back to the governing body with an outcome of that in the new year. And as Paul alluded to earlier, we had I thought, a really good, engaged market event last Friday with over 100 people attending. A whole ream of different organisations, small, medium and large, came along. So we're just working through the feedback and the plan coming out of that, but really encouraged with the feedback we had from the market, particularly our voluntary care sector, in terms of their appetite to work as part of this programme of work. Just on some of the more specific work that we've got going on. Again, good news in the community mental health space model. Recruitment's going far better than I anticipated. If you recall, we've committed to a significant increase in our mental health practitioners that are supporting our primary care networks. NSFT are leading that recruitment, supported by the GP Federation, and we've got a number of those posts now filled and further recruitment underway. That's in the context of every area is basically out recruiting for these posts at the moment. We've also agreed in principle, subject to the primary care networks supporting this, to create a number of children's primary care mental health practitioner roles. I think 7 is what we've initially committed to. So we're hoping in October to also go out to recruitment, subject to approvals for those roles as well. Ipswich and East Suffolk is one of the highest in the region in terms of our serious mental illness health checks, which is great news. We're at 44% at the end of the last quarter, which is brilliant. More to do, obviously, but we are high up there in terms of our performance related to that. And in terms of crisis services, we have got challenges in terms of demand on our first response, well, across the whole of a crisis service, if I'm honest, but particularly within our first response service provided by NSFT in terms of the volume of calls being made. We've got a recovery plan in development jointly between NSFT and the CCG that's coming through to us hopefully at the end of this month, early next month. And again, we can pick that up through the clinical executive. Briefly on children's, we are about to kick off a piece of work to develop a children and young people's framework, strategic framework across Suffolk, including Waveney, which will be sponsored by the County Council, the CCGs and our provider partners. Effectively, it's to put into place an overarching 5-year framework of what are we trying to achieve across Suffolk as a set of public sector leaders in terms of the change we need to make to improve outcomes for children and young people, which we can then better frame the programmes of work that we've got underway. So we're hoping to kick that work off later this year, early next. And finally, with children's, we've also now in the process of mobilising that whole spectrum of different neurodevelopmental VCSE offers, which is brilliant news for support both to emotional wellbeing hub, but more importantly to our families across Suffolk in terms of support they need. Last programme on strategic programmes, excuse me, which Narinda leads. In terms of cancer, we had a successful ICS Cancer Board again last week. A real focus, and again linked to what Paul was saying on some of the performance challenges. First off on breast cancer, we are now committing to effectively putting into place the East Midlands model championed by Professor Robertson, piloting a community-based approach to management of that, linked into ESNEFT and West Suffolk. We're also going to be doing an ICS-wide workshop on dermatology. We're also struggling within parts of the ICS in cancer related to derm. So a further workshop approach with an external speakers to challenge our thinking in November. And we're also re-looking at the Cancer Macmillan Navigators, which hasn't been as successful as we would have hoped. We're looking at an additional, a different approach. Hopefully it'll be coming back to the ICS Cancer Board in its next meeting. And then just to flag for October, that wasn't enough. We're also going to be bringing back some proposals around neurorehabilitation. That is also an important part of our work. I know, Mark, you're linked into effectively to look at what some options are around our level 2B and 3 provision linked to the successful mobilisation. Two things, both our stroke rehab service, which is now entered into business as usual, and secondly, our Parkinson's advice line, which is now back up and running as part of the ESNEFT offer, which is great news. And that was something I know the board was very passionate about backing, which we've made a reality. So I'll leave it there, Mark. Thank you.
Thank you, Richard. A lot to get through. Well done. Just going back to a term that Lisa used earlier, the Don. That's not a crime boss or a university lecturer, it's a director of nursing. Some might say it could be all three, but there again. In terms of the community mental health team, Richard, some really great news there, and I think it is going to be one of our biggest transformation programs over the coming 12 months. And just a note to self around how we put in the development support that those new teams will need in order to gel well and get on with the work in an environment with, which will be unfamiliar to most because of the multi-agency and multidisciplinary approach that's going to be required. So we need to think about how we do that, how we give them common purpose, embed the cultural approach that we know that works, and really cement team working in that community space. So thanks for that. Any questions or queries from anyone else with Richard's piece? Thank you. Very comprehensive stuff going on. Maddie, you want to talk about primary care?
Yes, thank you. So I'll be brief. I think we've covered today the position of primary care generally in terms of access and of experience. I just wanted to pull out three things. Mark, you mentioned in terms of our antibiotic prescribing, and that remains positive. I've today had our overall prescribing figures, so they're now for July. So we do remain over budget against the NHS England budget that was set for us. We do remain above the same position last year, although there is a small reduction over last month. But we have to be very careful with the variations between months. It can sometimes depend on a number of factors. So the overall position is that we are overspent. And I think that was something that we fully expected during the core COVID period when people were maybe struggling. But we do need to, and we are beginning to look at where the spend is and whether there are further areas where we can improve quality, safety and cost effectiveness. And many colleagues and members of the public will remember that a couple of years ago we launched a campaign which encouraged people to buy the medicines that they could over the counter because it was a safe, high quality, and it was a cost-effective thing to do. And we will be returning to that. We know that we had overwhelming public support through the Facebook page, and so we will be returning to that, because if people are able to buy those basics and have a well-stocked medicine cabinet through their pharmacy or through the supermarket, it does mean that they won't be going to ask the GP and for requesting an appointment, which where they could very reasonably and sensibly get those medications at the same time as other shopping. So we will be looking at that over the coming months in order to try and continue our commitments, as I say, on safety, quality and cost effectiveness. That's just to mention that. And I was just going to pick back up on the piece that Richard mentioned. He was absolutely correct, probably nothing left to say. The primary GP medical services will transfer wholly over to the ICS on the 1st of April. The exceptions of the function, there are a few functions that are retained by NHS England, and one of those is of the performers list. So the performers list is of the GPs who are able to practice, and that's a good and healthy separation of functions for us to have. And the other primary care services will transfer in due course, but there will be a shadow period of at least a year whilst that happens, which I think, again, it's been a while, is probably a very healthy approach, and we will work side by side with NHS England over that period. I think there are huge opportunities for us to work collaboratively within our integrated neighbourhood teams for all of the primary care contractors to be linked in with their other partners within the patches. So we look forward to all of that, and we know there's a big phase of engagement and co-production to follow to make sure that that's really positive for patients and positive for all of the partners in those areas too. So I wasn't going to say any more now, Mark, but I'm really happy to take any questions that anyone might have.
Thank you, Maddie. And any questions, anyone? Okay, in which case, is it Jane's turn?
It is, thank you. So included in the pack is the finance report for the CCG up to the end of August. So it includes the figures up to the end of August and a forecast till the end of the half that we're dealing with, so for the end of September. In terms of overall, the overall position is that through a combination of the resources given in our main allocation to the CCG and claims that we make against separate funding streams such as COVID vaccination, but particularly for Ipswich and East, the hospital discharge programme, we are reporting a balanced position for both the end of August and the end of September. But I think it's fair to update the governing body that it is extremely tight, and we took a deep dive to the Financial Performance Committee a couple of weeks ago on some of the pressures that are within the budget. One in particular that we are looking at in detail being in continuing healthcare, where whilst we still benchmark extremely well, we have seen a significant increase over the last couple of years in terms of high cost packages and overall demand, which, given we're funded at a 1920 level plus a very small uplift, we're struggling to deal with the cost increases of that within our overall tight budget. So that's all I wanted to say. Really, I think I've got to say it again that obviously we're waiting for the allocations for the second half of the year. So hopefully by the time we meet as a governing body next time, we'll be able to look at the progress overall for the remainder of the financial year.
Thank you, Jane. And thinking ahead to April and the new year, there's hopefully a bit more confidence we can have in how we manage our own needs, really, isn't it? So thank you for that. Any other questions for Jane? No. In which case, are we all done on that report? Have I missed anyone out? That's great, thank you. So shall we move to the governing body assurance framework? Graham.
Yeah, thanks, Mark. 2 points to raise, I suppose. One, there's a new risk, which is about system resilience, which I think we've discussed that in detail. And the second thing was the rack plank issue at West Suffolk Hospital, which we haven't touched on. And we thought when we had our last meeting of the rack plank committee, we said we should probably raise it in public at this meeting now. So if Paul could just say a few words about that.
Do you want me to go next? Happy to respond. Yes, thanks, Mark. Okay, I think it's fair to say that the rack issue, as I should call it, reinforced autoclave aerated concrete for people in terms of what it actually stands for, has been on our risk register for a little while now. So I guess, Graham, what you're asking for is a bit of an update as to where we've got to, I suspect. So I'd start off by saying that this issue has been well publicised, I think, so both in the national, local press and also by the Trust itself. It's been very open and transparent about the risks that are associated with that type of structure. It's also fair to say that the Trust have been working on this since 2010. So whilst the SCOS alert, which was a standing committee on structural safety, nationally came out in 2019, sorry to say, there was an issue. The Trust has actually actively been working towards some of the risk issues since 2010. So again, that's an important context, I think of the conversation. I think from a commissioning point of view, we got involved when essentially the Trust started to say there was fairly high risk. And I think that it's fair to describe the lenses through which we look at the risk. So we are not here to assess the risk itself. That is the predicament of the owner of the building, which is West Suffolk FT. But what we are here to do is to ensure that safe services are being commissioned. And we do that in a number of ways, I guess. The first way is to seek assurance that the right action have been taken by the Trust to mitigate any of the risks that have been identified, and more importantly, to make sure there is a right governance structure to be able to make those decisions with the right level of expertise within the Trust itself. And I can touch base on that shortly in a minute and come back to that. The second way we look at this is to say, so if we wanted to commission service differently to mitigate the risk, can we? And I'm sure you're aware, we kicked off a piece of work that did exactly that. And actually it's a fairly hefty document that looked at every services and what we could do with the services. The only thing I would say to that is that it's been picked up by our regional colleagues as good practice. And actually it's been sort of taken much broader into as an approach for other rack buildings sort of regionally and nationally. So again, quite an extensive piece of work there. The third element and where we'd look at it through would be patient environment. And again, we did some assessment around some of that in terms of the actual caring environment, etc. And that piece of work sort of has led us to having a view as to whether or not there are particular issues within that. And finally, it's planned for all eventualities, which is to say, you know, should something happen, then actually are we ready for that? And we have done some extensive pieces of work around our EPRR, worked across the system. We've just tested a response to an event which went really well. And that framework will find its way forward into our structure and governance structure and governing body as we report. And then there is a much wider business continuity conversation which is now taking place. So again, when you take all those things into the round, we feel really quite assured really that we are doing all the right thing given the current level of risk. Having said all of that, this is about current monitoring, current engagement, current constructive conversation with the trust, and we are constantly involved in the decision, the escalation, and with our regional colleagues in terms of how we manage that risk. So I think it's probably fair to say just very quickly that there are a number of things that are really sort of provide some assurances. The trust have a very active monitoring process on a daily basis, right down to core staffing, you know, notice something, say something approach. There is an absolute sort of a bearing extension program, which is due to finish in 2021. There is a fail-safe program, which is due to finish in 2023. And again, it is testament to the trust that they've actually suspended some of their elective activity recently and lost 50% of their theatre capacity and 2 to 3 wards to make sure that that safety is an absolute priority into both patients. So again, a lot of work, a lot of assurance around some of that. And finally, the only other thing I probably would add to all of that is the fact that when you look at what they're currently doing, they do meet all SCOS recommendation as I understand it, and very much having monthly regular HSCs involved, the CCG are involved, we attend the risk committees, etc. So a lot of very good communication. But as I said, it's part of an ongoing process. And then finally, the ultimate solution will be a new hospital, which we are planning to do about 2030, which is part of the future systems conversation at the moment. So at the moment, it is absolutely a risk. We have to acknowledge that it is a risk. But I think as a commission, we feel pretty assured that most of the actions that should be taking place are taking place. Does that help as a summary?
Yeah, thanks very much, Richard. I just think it was, like I say, at the last risk committee we had on that, it was said that we should actually report it in public as we hadn't done it for a while. So thanks very much for the update.
Yeah, thank you. So anything more, Graham, on the GABAT?
No, not. I think we need to raise now, Mark. No.
And any questions from any of the board members on what we've just gone through? No. Fantastic. Thank you. In which case, let's move on to the Audit Committee, the annual report. Jane and Graham.
Yes, thank you. Shall I introduce Graham and then you can pick up? Just to say that this is it does what it says on the tin, really. This is a report pulled together kindly by Joe on what's happened in the Audit Committee over the last year. We took it to the Audit Committee a couple of weeks ago for sign-off. But hopefully it gives you a flavour of it's to help the governing body to know what it is that we've been doing in that committee, which is ably chaired by Graham, who will give you more content.
Great, thanks, Jane. I think the paper itself is self-explanatory, so I don't plan to really go too much into that. I mean, we actually report in the actual annual report and accounts, we sort of update the committee's work in there. Also, we include the minutes of all the meetings at the end of this meeting as well, so I don't plan to go into too much. I mean, the main purpose of the meeting really is just to give the governing body assurance that the audit committee complies with its terms of reference and actually meets its specific obligations and duties, which are clearly set out in the paper. And I think, you know, basically the committee's well established. We work, you know, with external audit, internal audit, and counter fraud, and you know, it's a good group of people that actually meets, and it's you know, like I say, it's well established. So I'm happy to take any questions if there are any. Thank you, Graham. Any questions?
think as a governing body, we're very grateful for the work that you do and the way that it's done. And I think that the way that it's done is really important as well. So thank you. Thanks for that. So if we can move on to the Financial Performance Committee annual reports, Jane and Steve this time.
Yeah, so in a similar vein, this is the report on the Financial Performance Committee, which I have to match it by saying very ably chaired by Steve, who might want to give you a bit more background.
Yeah, very similar to Graham in many ways. But it's been an interesting year to be running the Financial Performance Committee, particularly in terms of making sure we had the correct balance of focusing on what is really important, which was vaccination, etc., while still keeping the governance aspect of the finances of the CCG being run in a very transparent and a very structured and a very challengeable way. And I'd like to take this opportunity to say thank you to all the staff in the finance team. I think they've done a wonderful job over the past year. So again, any questions on any details?
Thank you, Steve. And when you go into an emergency like the pandemic, and the way things get done have to change and become much more lighter of foot, governance can go out the window a bit, and risk then does start to accelerate, and we can see that from you can see that from a finance perspective. We can see it from an information governance perspective in the IT that was required, and being able to just keep a firm handle on that governance tiller around finance has been very welcome. Thank you. Any questions from any of the team? No. Thank you very much for that. In which case we'll move on to the minutes of the meetings. Graham, anything else that you wished to highlight from that?
Not actually from the minutes themselves, Mark. They're just statements of facts. But the one thing I have been thinking about recently is the Alliance Committee meetings. And where are those actual minutes of those meetings published? Because we're not seeing them through here. And I know, the Alliance is dealing the work within our CCG footprint, if you like. So just where are they published in public?
Maddie, do you want to talk to that?
Yeah, Graham, they're not at the moment as minutes. We've obviously consolidated into an annual report of the performance of the Alliance and provided regular updates. But I personally see no reason why they couldn't be, to be honest. I mean, we are talking very actively, and Ed might want to come in further about the kind of future model for how the alliances work with in the kind of family of alliances and with the ICS board. So I think there's some further detail to run on that. But for now, it's been through the publication of updates and the annual report.
Yeah. Thank you. So we can look at taking that as an action for future governing body.
Yes.
Yeah. Yeah. Thank you. Okay, and any other queries around that? No? Manuel.
Not on that specifically. I just wanted to comment something on the primary care commissioning. We have talked, and I think we've seen, quite a bit of not issues as such, but comments around, I suppose maybe not to say performance, but issues within the primary care sort of sector. And one of the things I wanted to highlight is that at the last meeting, we talked about the patient survey. And I think it's really important that, despite the challenges that we all understand, our primary care has gone through, in the majority, our patients are saying that, they are satisfied with the service that are being provided, and I suppose taking into account the challenges that we've all gone through. So sometimes looking in sort of social media or, in the main media, you might think that, things are bad, and yes, we know there are challenges, but I think it's important to take into account, some people who don't normally, put stuff out into media and other places who, have participated in some of these surveys, and they are saying that they are quite grateful, and I suppose we need to acknowledge that, because it has been a real challenge, for our teams within, primary care, going through COVID and everything else that we've gone through. So I just wanted again to take, this opportunity to acknowledge all those efforts that have been put in, but also to, thank our patients as well, who have been patient, with us as, we go through this difficult period. So thank you.
Yeah, thank you. And well, a nice point, well made, thank you. So we've come to the end of the business of the governing body. We've got our next meeting on Tuesday, the 23rd of November. So I'd like to thank everyone for their contribution today. We're going to move into the questions. And just a reminder to governing body members, we have a part 2, which will start as soon as the questions we've managed to answer then. Thank you. So Simon, have we got further questions for the committee?
We do, yes. We got a series of questions from Anthony Dooley. We've already answered questions from Mike Hope. So Mr. Dooley's question, his first one is, why was a tweet sent out from yourselves and others stating that 12 to 15-year-olds can now be vaccinated, when a head was quoted in the local press recently as saying he didn't expect those vaccinations to be available until November? If the intention was to communicate that 12 to 15-year-olds are now entitled to be offered a COVID vaccination, those are the words that should have been used. As it stands, this is the second time a tweet has communicated misinformation from Suffolk County Council, yourselves and others. Why?
So, Simon, did you want to take that?
Yeah. Wow. No, I'd very much, I could certainly answer that question. So the tweet that Anthony Dooley stated said that 12 to 15-year-olds can now receive the COVID vaccination, and it was issued on the 22nd of September when this phase of the rollout started. So that was wholly in line with the national and regional messaging. The article that Anthony Dooley referred to appeared in the East Anglian Daily Times on the 21st of September and quoted the head teacher of Stowmarket High School, Dave Lee Allen. Mr. Lee Allen said that he predicted the immunisation team will visit his school on the 12th of November. So we'll liaise with NHS England, who commissioned the service, to see whether Stowmarket High School could receive an earlier possible service. So we'll keep an eye on that.
Thank you. Next question.
The second question, again from Anthony Dooley, is as follows. I have previously asked both Ed and Melanie whether schools in Suffolk are COVID-19 safe. I'd like to ask that question again in the light of the data indicating that more than 1,200 students and 117 school staff have tested positive for COVID-19 since September the 12th. They are the most recent figures I'm aware of, and the statement from Stuart Keeble in the local press that these cases were expected because of the relaxation of processes to protect staff and students. Why did Ed, along with everyone else on the Health and Wellbeing Board meeting held in July, support Stuart's call for everyone to be courteous, etc. to one another, when we all knew that that would be totally inadequate approach to protecting, for example, school communities come September? Why are you colluding with the policy of herd immunity for our young people? Already more than 80 deaths of young people have been recorded nationally. I thought the Hippocratic Oath stated, do no harm. Why, as a local system, are you failing our school communities, is his question.
Okay, just while directors and others are going to come back on that, I just want to come to the Hippocratic Oath and first do no harm, because the second line to that is the second, try to do good, and be helpful, and every intervention that potentially could be of help can also be of harm, and it's about how we balance all of these risks together to be able to get the best outcome for people, because there is certainly nothing much in medicine that comes without the potential to do harm, and it's how we balance all of that that will be important. But in terms of those other issues, Ed or Lisa, do you want to make any comments?
I think the specific issues around schools should be addressed by Suffolk County Council Public Health, but the context of that Health and Wellbeing Board was we were lifting the lockdown, and the conversation was around how we continue to be vigilant, cautious, courteous, compassionate, all of those things as we lead our lives normally with the virus still circulating. So what we were talking about was protecting people, not what Anthony's describing, which seems to be the opposite. So I refute that suggestion, Anthony.
Thanks, Lisa. Thank
you. I can't give any personal assurance on school settings around COVID safety, but I can tell Anthony that our IPC teams with school nursing and education have all worked incredibly closely together to make sure that all the IPC guidance has been understood by the education settings and is being applied. And at Health Protection Board, which is a stakeholder board that oversees COVID arrangements in Suffolk, there is always an update on outbreaks in schools and any recommendations, any learning. And I've personally found the education and Suffolk County Council to be incredibly collaborative around making sure that they are adhering to guidance. So that's the only perspective I can give. Thank you.
Thanks, Lisa. And any other questions?
There are a further question or two here from Anthony Dooley. The question is as follows. I emailed Ed with a question, in effect asking his view on those who might be eligible to sit on ICS boards should there be a new Health and Social Care Act passed in Parliament in the near future. Specifically, there is the question of private providers such as Virgin Care, who sit at the moment on an ICS in the West Country, and the question of public patient representatives sitting on such boards to provide some sort of local accountability. He asks a follow-up question then, does the CCG support the call for such full funding to address the waiting lists?
I'm struggling to connect the two together.
Yeah, I'm not sure that they are connected, Ed. So let's just go in with the first one in terms of the ICS board makeup.
Yeah, so I've shared with Anthony all of the national guidance, which you can see on the NHS England website around integrated care boards, and that's as much as we have published. I think his concern is about whether there'll be private sector providers on the integrated care board in Suffolk and North East Essex, which I think would be very unlikely, but that board hasn't yet to form, and a final agreement on its composition hasn't been made. So my sense is that would be unlikely, but we'll see once the boards come together.
Thank you. And can you just remind us of that final question, Simon, about...
Yeah, so the additional question is, does the CCG support the call for such full funding to address the waiting lists?
James, do you want to? Yeah.
Go. I can offer a personal perspective on it if that's okay. I think you need to look at that question in the context of all the effort that our provider and the system are taking in terms of increased productivity. They are trying to do more with what they've actually got. They are certainly constrained by ICP infection control measures, which they have to adhere to, which is absolutely the right thing to do. And ultimately, there has been, a backlog of patients requiring, important surgery and elective activity that is built up over the COVID period, and that will require funding. I think there are some very strict criteria being attached to that funding moving forward to demonstrate we are using every penny, every pound that we have as productively as we can. So personally, I cannot see how we can recover elective activity without some additional funding, but absolutely accept it has to be a system and a partnership approach to actually recovering those waiting lists. That's what I would offer as a personal view.
Thank you, Paul. And have we had any other questions come in whilst we've been underway, Simon, or are we finished?
We are finished. No further questions. Thanks.
Okay. So thank you, everyone. I'd like to now bring the meeting to a close.